Hi, this is Dr. Kerry Gelb. I'm excited to be doing ODwire again this year. This year I'm going to be partnering with Dr. Jeff Gold, who's a cardiologist. Dr. Gold and myself, we refer patients to each other. We do a all-day presentation on blood tests and diabetes, etc. So I'm really excited to have him with us, and we're going to kind of do like a question and answer. So this is kind of a part two to the blood test lecture that I did last year. I want to introduce Dr. Gold and let him give you a background about himself. Dr. Gold?
Thank you, Kerry, and thanks for inviting me, everyone. It certainly is a pleasure to be here and to get to talk to you about an important topic and one that you may not have familiarity with, but hopefully by the end of the lecture, you'll be a lot more comfortable with. So my background is I'm a board-certified cardiologist in private practice. I've been in practice for over 20 years. I do a lot of clinical cardiology and spend a lot of time in the cath lab, but as part of my practice, preventive cardiology is an important component, and I spend a lot of time reviewing patients' labs.
So here we're looking at a patient who came in with a white center hemorrhage that we all know as a Roth spot. Now this is a good example of a patient that we would work with a primary care physician or a cardiologist, because we know that a Roth spot could sometimes be associated with subacute bacterial endocarditis. But we're going to see and practice a number of types of cases where we're going to need to refer for blood tests. So I'm going to ask Dr. Gold, if I refer you a patient that I show you that has a white-centered hemorrhage like that, and we do a number of blood tests, what are some things that you're going to be looking at on the blood work, even though you may not, as a cardiologist, be that familiar with looking at retinal scans and retinal blood vessels, but you know, cardiologists and optometrists, we're both looking at blood vessels, but just in different parts of the body. Dr. Gold?
Yeah, so in this particular case, if we're concerned that the patient has a Roth spot, as Kerry alluded to, it's typically an embolic phenomenon from subacute bacterial endocarditis. We would certainly want to evaluate for blood cultures. We would start with a CBC, which we're going to go into in greater depth later on to look if there's an elevated white count suggestive of a bacterial infection. We also may want to check for some inflammatory markers like erythrocyte sedimentation rate, and so forth.
Jeff, when you're doing scans and looking at the blood vessels in the heart, how much different is it than when we're looking at the retinal blood vessels?
You know, Kerry, although I don't have the expertise that you do looking at the eye, when we look at the vessels of the heart, really blood vessels are blood vessels, whether they, supply the heart muscle or the eye or the brain or any other part of the body. So the blood vessels are pretty uniform throughout the body.
So if I'm seeing, or another optometrist is seeing something wrong in the eye blood vessels and the retinal blood vessels, is there a good chance that there's something wrong with some of the other blood vessels in the body?
Absolutely. There's an excellent chance that there's a problem with other vessels in the body, and it's probably an early indication as to what's going on. And we see this all the time. Patients with peripheral vascular disease typically have coronary artery disease and vice versa.
So who should have lab tests? Where should lab tests be done? I'm asked this question quite a bit as myself and Dr. Gold travel around and give this lecture. Lab tests can be done in most states. I don't think this is something that you need to worry about. There are states where you could just walk in and have your lab test done as a patient. You don't need a doctor's prescription. I believe Arizona is one of those states. You could go online and take your blood and go to one of these online labs, and the lab will send it in you to your own blood test. So optometrists doing blood tests, it should not be an issue at all. And especially with all the pressures that we're under with our profession, with online exams, making believe and saying that they're a comprehensive eye exam, we want to be able to provide more comprehensive services to our patients. So let's take a look at who should have these lab tests. First is any cataract patient that's young obviously should have a lab test because we're concerned that they may be diabetic. People who have RX shifts, especially in the myopic direction, we were taught in school that that's typically diabetic. I find in clinical practice it's more of a hyperopic shift. So if you have a big RX shift, either way, I would consider doing a lab test. Any kind of vascular disease that you see within the retinal vessels, whether it's cotton wool spots, retinal hemorrhaging, or, of course, retinal plaquing or plaques, Hollenhorst plaques. Multispectral imaging, we could pick up microaneurysms very early, something we'll discuss as the lecture goes on. Somebody with corneal arcus, this is a little bit of a controversial subject, but I could tell you in clinical practice, since I do a lot of lab tests, patients who have corneal arcus generally have elevated lipids, that they are correlated. People with signs of diabetes, such as skin tags, acanthosis nigricans, when you see pigment in the creases of the skin, abdominal obesity, and sometimes you'll run lab tests and then patients will request if you could write them a lab test. Dr. Gold?
So part of the reason for giving this talk today is to help you to identify subsets of patients who may benefit from having lab tests. As optometrists, you are in a unique position to help evaluate and identify some of these patients at an early stage. We know from the statistics that optometrists see more patients annually than family practitioners or general internists. So based on the numbers and the fact that you see so many patients annually, if you pair the imaging that you have available to you with the information you're gaining from the lab tests today, you'll really be in a great position to help to identify these patients early. We know that identifying people early are important because we could provide the most benefit at the early stages. So let's focus on the diabetic patient. As you well know, diabetes is a leading cause of blindness in patients under 55 years old. It is rampant and one of the things that you're going to see commonly in private practice. Some of the ways that we could help to identify patients at an early stage are by drawing either fasting or 2-hour insulin levels. Additionally, we can look at a hemoglobin A1C, which is our ability to measure the patient's blood sugar over a 3-month window.
And this is a slide that I often show in many of my presentations, and I did show it last year, but it's just to bring home the point that there's about 115 million visits to primary eye care providers per year, where there's only about 40 million visits where people go to family practice or internists where they would have their blood drawn. So we're seeing almost about 2.5 times the amount of patients that would go to primary care. There's 177 million people in the U.S. that wear some kind of vision correction. So a lot of people are getting their eyes examined. So it's very important that we understand how to do these blood tests because we could help a lot of people. And more optometrists are doing blood tests at this point. Dr. Gold?
When I first saw this slide, I was a little bit surprised, to be honest with you, living in the subspecialty world. But this really depicts the importance of the optometrists in the screening of the general population. Due to the fact that you see so many patients at an early stage, it really puts you in a unique position. I get many referrals from optometrists that are well thought out, and I think by reviewing the lab tests and getting some more familiarity with it, that you'll be even in a better position to identify these patients and help identify them at an early stage, because that's really what we're looking for.
when we see vascular changes in the eye, whether we're seeing a retinal hemorrhage or a microaneurysm or cotton wool spot, it's not always diabetes or hypertension. There could be other different vascular diseases that we don't want to forget about. So, in addition to diabetes and hypertensive retinopathy, there's sickle cell could cause hemorrhages and vascular changes, anemia, leukemia, hyperviscosity states, radiation retinopathy, HIV retinopathy, and ocular ischemic syndrome. So when we get back to lab tests and we find some abnormal lab findings, and one thing that's not on the list is if we see retinal plaque, such as a Hollenhorst plaque, that we're going to refer to cardiology. But when we get back, whether it's a retinal hemorrhage or a cotton wool spot, and we send it to primary care because of the abnormal lab finding, how is primary care going to handle something like that, or cardiology?
So when we look at this slide, diabetes and hypertension are two of the most common conditions that we see, and they're vascular diseases. So there are many tests that we could order, but basically we've touched on diabetes a little bit. As far as your hypertensive patient, as you know, uncontrolled hypertension both has acute and chronic consequences. On an acute level, if the blood pressure is markedly elevated, patients could unfortunately suffer a stroke. As a more chronic condition, it affects the vasculature, it could affect the eyes, it could affect the brain, it could affect the heart and the kidneys. So there's opportunities early on through these lab tests, one being an SMA7 or BMP that we're going to talk about, to identify kidney function, which may be an early indicator. As far as the sickle cell retinopathy, the anemia, and the leukemias, those could be identified early on with a CBC.
So, Jeff, I'm really interested in the new guidelines for hypertension and how that's working in your practice, how you're treating your patients. And number two, also interested in the medications, your favorite medications for hypertension, which ones you think work the best, which ones you think don't work so good, and which ones maybe have some side effects that we could be looking for as optometrists.
So that's an interesting question and one that's very topical. As you know, the new guidelines for hypertension recently came out. Interestingly, the guidelines for diabetes 20 years ago were much different than they are today, and it's the same for hypertension. We used to accept blood sugars and blood pressures that were much higher, but we've come to realize that if we don't treat those patients or they're left at those high levels, that their disease prevalence is much more rapid and progressive. So over the years, the trend has been to more aggressively treat those patients. Now, by treating the patients, it doesn't necessarily mean that we're going to medicate them. We always try an approach of lifestyle, diet, nutrition, exercise, assuming that their blood pressure is not in a dangerous range. If after a period of time we implement these lifestyle changes and the blood pressure remains suboptimal, we have the option to treat with medication. My general approach to treating these patients is one where we start with low doses of medications. There are many different classes that we use. Typically, when the patients come to me, they've had some disease for some time, so I'm seeing a skewed population. Typically, my preference up front are calcium channel blockers that are well tolerated. I also like to use a class of medication called ARBs, ARBs. They're angiotensin receptor blockers. My approach to treating these patients is to start on a low dose of the medication and slowly increase the medication as tolerated. But what I like to do is use medications in combination, because I find when I use low doses of different medications, the patients have a synergistic effect and we minimize the side effects as opposed to